Awesome. Thank you, everybody. Rob Manske, Wichita State. Thanks, sponsors. And before we start, I have to say congratulations again one more time to our guy, Phil Page, for his big award last weekend.
Thank you.
Way to go, Phil.
Hall of Famer.
Hall of Fame. He got a blue jacket, Rachel, that he wore around the rest of the conference. He's quite a big deal in the sports section. That's Phil Page. Phil, do you want to introduce yourself real quick?
Everybody, Phil Page, Baton Rouge, Louisiana at Fran U. This is number 33. Is that right?
It's 33. You got it right.
First time I got it right. That's what getting in the Hall of Fame gets you. Get it right finally. So thanks to our sponsors. Thanks, Dr. Frank, for being here. Thank you, Ashley, for putting this all together. And Rob, love you, man.
Thanks, buddy. All right, guys, let's get started. I want to introduce our guest, I guess not our first speaker, but our guest, Rachel Franks, a board-certified orthopedic surgeon and sports medicine specialist who focuses on surgical and non-surgical management of the knee, shoulder, and elbow injuries. She specialized training and technical expertise in the area of advanced knee and shoulder arthroscopy, cartilage, meniscus restoration surgery, shoulder instability surgery, and care of the female athlete. She presently serves as an associate professor in orthopedic surgery at the University of Colorado School of Medicine. She is the director of the Joint Preservation Program at the University of Colorado and is the biologics physician champion for the Department of Orthopedic Surgery at the University of Colorado. I've seen Rachel speak at many meetings. I'm sure she hasn't seen me, but I've seen her, and I was very fortunate enough. Ashley, Mike, and I were really fortunate enough to go this summer on it was like an allograft tour. You know, we took a bus ride around Denver, going to different locations and learning about allograft sources. And Rachel was there helping guide us through all of those tours, and we kind of grabbed her toward the end of it and tried to coerce her to come on the journal club with us, and she so kindly said yes. So Rachel, thank you very much for joining us tonight. Is there anything else you want to add from what I read about you?
I think the only other thing is I'm a team doc for the Rapids, and we played, I think, the coldest ever soccer game in the U.S. last night. And by we, that's a generous use of the word we. I just sat there freezing, and was an interesting experience for all.
Awesome. Well, Rachel, I thought before we start digging into the articles that you sent, I thought you did just a fantastic job telling a little story about yourself and your injuries and how you got into orthopedic surgery on the allograft tour. I just wondered, I thought it would be really great for all of the people listening maybe to learn a little bit. I mean, I thought it was really a special little story that you told, and made me feel like I knew you better and understood really why you do what you do. I was wondering if you could give us like an abbreviated version of that as we start tonight.
Sure, absolutely. And thank you so much for having me. And Phil, congrats. And thank you. And Ashley, thank you for organizing all this. And to everyone on the webinar, I can't see you, but you know, everyone's strapped for time these days. And I really appreciate you guys taking an hour out of your lives and your family and your job to spend some time with us. And hopefully, hopefully you get something out of this hour. So thank you all very much. And so my story, whenever I give a talk about joint preservation, one of the first things I do is ask everyone in the audience to raise their hand and say, how many of you have had an injury or had a family member with an injury or know someone that you love with an injury? And every hand goes up, right? Everyone's been part of that, has had that as part of their background, and I'm no different. And so I was a college athlete at the University of Illinois and had a meniscus tear, and that meniscus tear on my lateral meniscus left knee led to a meniscectomy. No big deal. Went back to play, and then I tore some more of that meniscus, same knee, had another meniscectomy, no big deal, went back to play. Now we're in my senior year, and I'm having a lot of trouble just walking, let alone playing. And so I was experiencing what many of our athletes experience, unfortunately, which was deterioration of my lateral compartment after what was seemingly a simple surgery with a very good surgeon who I still love and respect, and these things just happen. So ultimately, the Cliff Notes version is over the next 5 years, I had 5 or 6 more, or over the next 6 years, I had 5 more surgeries, so 7 total, including a couple meniscus allografts because I maybe abused the first one, an osteochondral allograft, some second look scopes, etc. And knock on wood, since 2011, I'm surgery free on that knee. But I've made better choices with my knee. I understand what the cartilage and meniscus allografts are intended to do versus what we hope that they can do in some lucky cases. And so that's kind of the Cliff Notes version of my knee. And I've been through, gosh, blood, sweat, and tears with my physical therapist, with her physical therapy team back in Chicago when she was practicing there, back when it was Athletico and then accelerated physical therapy. And those were my two homes away from home when I was in med school and ultimately residency. And so I have a deep respect for the whole healthcare team when it comes to sports medicine. You know, I can't do, and I tell my patients this, I can't do what I do if our therapists don't do what they do. I just had a patient today who wants an ACL done before his insurance runs out at the end of the month. And I said, you know, like, yes, surgery is the big expense, but you're going to need physical therapy for about 5 months. That's not free. And I'm not doing your surgery if you're not going to promise me you're going to do therapy because it's a waste. So anyway, I have a big appreciation for everything that you guys do, and you make our work look really good. We look good in the OR most of the time, and then you guys make us look better after that. So that's my story, and that's why I'm a big knee nerd. I love all things ACL, meniscus, cartilage. I love the other joints too, and do a whole heck of a lot of shoulder work. But when it comes to keeping joints young, keeping joints healthy, and when we can't do either of those, keeping them functional, I could think of nothing better to do with my time.
Thank you. That's a great story. And again, I think that lets all the listeners know kind of who you are, where you're coming from, and what your passion is. Okay, do you want to jump into our first study? Let's start with the D'Ambrosi, I think is the name of the study. And so this study aims to evaluate and compare the time required to return to sport after surgery, the rate of revision surgery, and the time required to return to sport after revision surgery in elite athletes undergoing meniscal repair or partial meniscectomy. So Rachel, what it's drawing a distinction here between meniscectomy and meniscal repair. What are some of the main factors that you consider when trying to determine whether to perform a meniscectomy versus a meniscus repair? And my guess is that you do the imaging and things like that, but you aren't ever fully 100% sure what you're going to do till you go in, right? Till you stick the arthroscope in and take a look.
Yeah, it's such a simple diagnosis and yet such a complicated discussion with patients sometimes. And especially with athletes, because a lot of athletes want to just have it out, believe it or not, because they want a faster recovery.
Mm-hmm.
A lot of parents of young athletes want it repaired at all costs, unless they're the parents where their kid's going to be the next Olympic gymnast and they can't skip a season and then they just want it out. And then there's that next subset of people kind of between ages 30 and 50 that have done research or educated, and they want it saved at all costs because they know or they've heard that if you don't save the meniscus, you're going to go on to arthritis and need a knee replacement, or at least that's what they think. And then there's the other factors that, MRIs are not perfect. Sport matters, age matters, chronicity of the tear matters, and quite frankly, luck matters, and you hate to hear a surgeon say that, but sometimes I can pick the perfect patient. I think I execute the perfect surgery. I know they've done the perfect rehabilitation, and for some reason that meniscus just doesn't heal, and that's unfortunate when we try to repair. So while I feel that I get a good understanding of the diagnosis from their symptoms, their story, and the MRI, a lot goes into surgical decision making when I actually get my instruments on the meniscus. There's very rare instances where I'll consent someone for either a meniscectomy or a repair. In most cases, I'm consenting them for both and asking them to let me use my best judgment for what I think needs to be done. There are certain cases where I know I'm going to repair it. I'm going to repair at all costs, even if it's got almost no likelihood of healing. And that's usually teenagers, where if you take out the whole meniscus, we know what's going to happen. And there are also some cases where I go in and I know I'm going to take it out because there's arthritis. This is just a bucket with mechanical symptoms. I'm not going to save the world. I'm just trying to save their knee for the short term. But other than that, it really can be an either or situation, depending on what I like to teach the residents, the personality of the tear. You got to get to know it a little bit before you decide what to do with it.
And so so you have sometimes in people that just want, you'll go in not knowing for sure 100% what you're going to do, and will they tell you, we just want you to trim it out?
Yeah.
so I can get back sooner. But then when you do the surgery, you make the decision once you're in there, right? Or do you ever just do a meniscectomy when you could have repaired it?
Only if we've talked about that ahead of time and they've
Yeah.
not given me permission to do the repair. And that is hard to get into my operating room with that on the consent form. So
Okay.
that's
I
a big
think it'd be hard.
discussion. Yeah, it's almost always with a teenager or someone in their 20s where the joint's otherwise pristine. They have a fresh meniscus tear with or without an ACL or other injury. And typically, if it's with an ACL, they'll always let me repair it if I feel like that's best. The acute isolated tear, the most classic one is like the football player mid-season or in season with an acute radial lateral tear that I would want to fix every day of the week and twice on Sunday, but he's out for the season if I do that. And the coach, agent, NIL, parents, everyone weighs in now, and they just want it out so he can come back in a couple weeks. If the patient really wants it out and they're a teenager and I think that that's the wrong move, I'll have the difficult conversation and say, we're in Colorado. You're going to find a lot of good knee surgeons, a lot of surgeons that I trust. I don't think I'm your surgeon because I don't think this is best for you. I think if I think that the meniscus tissue is viable for repair, I have to treat you the way I'd want to treat my family members, and I'd want this repaired. If it can't be repaired, that's a different story, but I haven't really met a young meniscus that can't be repaired. So there are some who do ask for it out. And if I think it's reasonable, like a bucket handle medial in a wrestler, that's a reasonable thing to take out because that's almost never going to heal. Or like a hockey goalie, bucket handle medial, that's almost never going to heal because of the position these guys put their
The
and gals
stress,
put their knee
they put
in.
on it. Yeah. Yeah.
I don't have a big concern when we talk about risks, benefits, and I tell them, look, the risk of going on to bad problems is worse with meniscectomy than repair, but the chance of a successful repair, as you've seen in the papers we're reviewing, may not be as good as we'd like. I'm okay taking that out in some limited cases, even in young athletes. And I think we talk about this at every conference. I think most of my colleagues would agree, but there are certain tear patterns that I will not be comfortable taking out. And I have a very candid conversation. And I'll tell you, saying no as a surgeon is one of the hardest things in the world to do. Your ego gets in the way. You want to help the patient. You want to be there for them. But ultimately, we can't electively harm patients. And I think in some cases, we have an opportunity to do that. And we've really got to avoid that if we can.
Yeah, that's great. Great answer. I appreciate that. We have, I think a lot of times we have some students on and we don't always know where they are along in their curriculum. So this article talked about the different zones, the red, white, and it talked about of the meniscus. And then it talked about tears that are reducible. Can you just, for the student, I think most of the therapists probably know what the red, white, white, and all of that is. But could you discuss that just briefly, what those mean, and then what does reducible mean? Does that just mean you can pull it back together? What does reducible mean in meniscal surgery?
Yeah, let's start with the second part first. So when we talk about a reducible tear, we mean that the tear can be put back to where it started from. So the classic one that we think about with this is what's called a bucket handle tear. And a bucket handle tear is basically a piece of flipped meniscus. If you think about going to the beach when you're a kid, or if you have kids, going to the beach with your kids, and you're holding a sand bucket, right, that you're going to build sand castles with or something like that, and you have the handle holding up, that handle can flap down or up and you can kind of windshield wiper it. You can think of that like a piece of meniscus that's torn. And so if it's flipping up and back, it's going to be displaced. And sometimes if that piece of meniscus has been torn for a long time, it can become irreducible, meaning no matter what we do in the OR, we can't push it back or get it to stay back where it tore from. And in those cases, we would resect those pieces of meniscus. That's very rare. I almost always can repair or reduce a meniscus. Then the question is it worth repairing? So that brings us to the second part of your question, which was really the first. And that's where the meniscus tear is. So this is an evolving topic. Dr. Arnowski back in the day, Russ Warren and others have really described the anatomy of the meniscus and the meniscocapsular junction. It's a little different on the medial and lateral side, but big picture, if you divide the meniscus into thirds, the outer third, so the part that's closest to the joint line, closest to the capsule, that's got the most blood supply. That's the good stuff. And so we call that the red zone, red for blood. As you move to the innermost part of the meniscus, so the part of the meniscus, either medial or lateral, that's more toward the center of the knee, more toward the ACL, etc., that's the white zone. It tears easy and it doesn't have good blood supply. So when the white zone tissue tears. Even if I do a perfect repair and you rehab a patient perfectly, the chances of healing go down. And then in the middle third is kind of the red-white zone. We're learning more and more. Jorge Chala out of Rush and others have really looked at these capillaries that go through the meniscus. We're learning that we probably can repair more menisci than we used to. We used to be in the past really strict on just repairing these red zone tears because we thought red, white, and white, white would never heal. Now we're learning that with some of our novel techniques, biologics, and really enhancing the repairs, we may be able to get some previously thought irreparable tears to heal, even in the white zone or red white zone. And then lastly,
awesome.
and anatomy-wise, there's the roots. So each meniscus has a root in the back and a root in the front, or kind of the posterior horn or anterior horn, respectively. Those roots are out of this talk of red, white, and white, white, and all that. Roots are important. If you don't have a root, just like the roots to a tree, you don't have a tree. So you need those roots to be attached or fixed if they're torn, if you want that meniscus to survive.
And how do you do you tear it? Do you have a root tear? Is it the same mechanism as the other typical tears?
Good question. You know, we see roots all the time, and it's such a hot topic in meetings that we've probably recognized them more in the last 5 years than in the previous 50. Roots kind of fall into two flavors. First and foremost, most frequently, it's the posterior root that tears more so than the anterior root. And the two flavors are kind of the older, more degenerative root tears that occur on the medial side, the posterior medial root. Patient kind of takes a misstep, steps off a curb, just feels a pop in the back of their knee doing something, but it's not a big athletic injury, although it can be. It's just more commonly low energy. And those are the ones we really want to get in and fix quite urgently if the patient doesn't already have arthritis, because we know even if they have a little bit of arthritis, we can prevent that meniscus from really deteriorating if we get it fixed. So those are ones we try to get in for. We don't try a non-surgical approach first. We don't try to rehab that or inject that. We try to surgerize that. The lateral roots are more commonly associated with ACL tears and more commonly associated with a traumatic injury in a young patient. You can get a degenerative lateral root, but we're not really fixing those. Those are not really the arthritis roots. But lateral roots tend to lead more to instability. And when you recognize those, you want to treat those.
The in this article, they were talking about that there are more repairs on the lateral side of the joint and more meniscectomies on the medial side of the joint. And is that, or do you, from your practice, is that just kind of coincidence, or is that because you just want to, because you want to preserve more on the lateral side, because the lateral meniscus has more coverage of that side of joint than the medial side, or what is the reasoning for that?
You're spot on. I think it's exactly what you said, and with an extra bonus. So anatomically, the lateral meniscus covers more of that convex tibial plateau than the medial side, and the medial tibial plateau is more concave. And so that lateral meniscus covers greater than 2/3 of the surface area of the plateau. So you trim out a little bit, you're going to have a big problem with contact area between the femur and the tibia. Medial meniscus, it still covers a lot of surface area of the medial plateau, but not as much and compared to the lateral. And the medial is more concave, and so it can tolerate a little bit more load with less shock absorption due to the meniscus. So you're spot on with that. The other really important factor is that there are great perimeniscal capillaries and vascular supply really around that lateral meniscus, more so than the medial meniscus. Thinking about popliteal artery anatomy, a little bit more lateral than medial in most cases, and all the branches that come off. And so when you repair a lateral meniscus, it's probably going to heal if you get at it early. They're a good candidate. You do a good job. They do good rehab. Meniscus on the medial side with repair, you could do all the same things, and that bad blood supply just really hoses you sometimes. And so a lot of those patients go through their rehab, they atrophy their quad because they're going through rehab, they get back, and then they pop it because it never really healed to begin with. The sutures were holding it in place, but it never really healed. And then they're frustrated and miserable and have to go back to surgery in many cases. Yeah, and so it's not that we don't want to repair the medial side, but I think this article is spot on in terms of the distribution of my practice and certainly what I'm seeing when I go to meetings and talk to colleagues.
Perfect, perfect. We usually have, Rachel, we usually have some good questions from the people that are on, and so we have a couple here that I think I'll shoot to you here. This is from Danish Mazzucco M. Any opinion on combining bucket handle meniscus repairs with orthobiologics as a means of bolstering the surgical outcome? You mentioned it very briefly. What kind of things are being done now with orthobiologic and meniscal repair? Can you expand on that a little?
Yeah, I would say the literature here is mixed. You can find a study to support the use of biologic augmentation or not. What I would tell you is number one, every meniscus repair I do gets some notch marrow venting. So we'll take a microfracture awl or a drill and we'll drill the notch just anterior to the ACL and try to get some bone marrow cells coming out to help bathe that meniscus repair in biology. I also will augment with PRP if the patient's willing to pay for it. In our system, and really every system, it's an out-of-pocket cost, and it can be quite costly. Ours costs around $1,000 just for one shot. But the evidence that is available really does support the use of PRP for meniscus repair healing relative to no PRP. What we don't know is what type of PRP, how much to put in, when to put it in, should we augment post-op, et cetera. There's still a lot of unknowns. But if it was free, I would put it in everyone I'm doing a repair on. So in terms of augmenting a bucket handle, yes, absolutely. The times I don't use PRP are number one, if a patient doesn't want to pay and I'm still going to marrow vent the notch. Number two, if I'm doing like a concurrent ACL, I don't feel that I need that biologic, although maybe time will tell, maybe it'll be helpful. You get enough marrow venting from the drill tunnels for the ACL that you probably are getting nature's own PRP right then and there. The question is, do we need to concentrate it or somehow modify? We don't really know the answer to that. The other biologics like cellular treatment from the bone marrow, from adipose, we're going to learn about synovial stem cells as well. They just haven't borne out to be as beneficial as PRP, and they're certainly a lot more costly. So my MO is to use PRP or just marrow venting. And then for the meniscectomy, I don't really use biologics unless the patient wants that at the time of surgery. There's some data to show that it probably doesn't make a big difference. Full disclosure, I get PRP in my knee a couple times a year. I didn't for about a decade after my last surgery, but I had a ski injury a couple years ago. I do not belong skiing. If you ever are skiing you're on the lift and you see someone like looking really nervous and scared like this on a green, that's me. And so I had a crash a couple years ago and my knee blew up and there's not much left to salvage anymore. So we just got to manage. So I like PRP for arthritis and inflammation, but there's not enough evidence for me to say to my patients it's something you should spend money out of pocket for the meniscectomy knee.
Yeah. Adam Rosinski, I'm butchering his name. Sorry, Adam. I apologize. I can't. How do you say it, Ashley? We met him.
Yes.
We met him this summer. Shout out, Adam.
Ruskowski. I think that's
Ruskowski. I don't know why I couldn't say it tonight. I just couldn't say it. Sorry, Adam. I apologize. I love you, man. You're great. What is your thought flow, Rachel, on choosing a conservative approach for meniscal lesions with PT versus opting with surgical intervention? How long are you going to wait? What are you seeing before transitioning to a surgical approach? And what is your experience? This is a big question, Adam. Maybe we should stop there. There's like 4 or 5 questions here.
It's such an important question. It really depends on the patient and their symptoms and the type of tear. So root tears, I'm going in for surgery unless I have a reason not to. What are those reasons? They'll never comply with the rehab. They got to be on crutches for 6 weeks, and it's real crutches, toe touch weight bearing. They're so arthritic that there's no point in saving the joint. They should just get a total joint when their acute symptoms from the tear get better. They, smoker, unhealthy, not going to comply, and nothing's going to heal with that kind of biology. Otherwise, I'm taking them, even if they're a little bit older. So medial root tears go for me. No, and I do not recommend a conservative approach, but there are some patients who insist on it, and I never force surgery, right? So if they're willing, if they don't want surgery, then we'll get them in with the best therapist I know and try to get them rocking and rolling, maybe consider a PRP. Bucket handles got to go because their knees locked. So mechanical symptoms are a big indicator for surgery. Everyone and their mother and brother and sister and father and anyone they have and their dog has cracking in their knee. That's not a mechanical symptom. When I say mechanical symptoms, I mean true catching that stops them in their tracks. They can't roll over in bed because their knee's catching. They can't bend over to put on their socks because their knee's catching. Clicking, I don't really care about unless it's super painful and I can point to exactly where it hurts. So not every knee with noise is a mechanical knee. I mean true mechanical symptoms. That's probably not going to get too much better with therapy alone. That's a mechanical problem, needs a mechanical solution. Pain with a more chronic tear, unless they're a teenager, I like a non-surgical approach, and I like them to maximize that. Surgery is best for mechanical symptoms and best for fresh tears. So chronic tears where pain is the primary symptom, I'd rather them try and fail physical therapy before I take them to the OR. The one exception is kind of that teenager, collegiate, or professional athlete where typically they're not chronic, they're acute or subacute, and their cartilage is pristine and they have a tear. I feel like those warrant a repair. I don't oppose anyone for waiting a season and trying to rehab the crud out of it, and it's not going to hurt them. They're going to get stronger and be a better candidate for surgery. That's kind of how I break it down. So true mechanical symptoms, tears that the knee would deteriorate without repair, like roots, those go. Displaced bucket handles, those go. Radial laterals, those go. Those got in the younger patient, the younger athlete, those have to go. Everything else I try to manage with non-surgical treatment. And believe it or not, that's the majority of our tears, right? The majority of patients coming in and they have their MRI report and they're like, okay, I need a surgery. And I'm like, you absolutely do not need a surgery, and surgery may make you worse. Go see this therapist and let's figure this out.
See how you do. Yeah. Yeah. Perfect. Perfect. Morgan Ivy, shout out to Morgan. Do you guys remember Morgan from December and January with Kevin and his group? What are your thoughts on weight bearing locked in extension after meniscus repair based on the type of repair? So do you vary your weight bearing status with different tear types?
Really good question. And yes, so roots, radials, and transplants are all toe touch weight bearing for 6 weeks with the brace locked in extension. I let them take their brace off to get in the car. I let them take their brace off to sit at a movie or sit at dinner. But if they're walking with toe touch, I never make anyone non-weight bearing. If you've ever been on crutches, non-weight bearing is miserable. So they can always put their foot down to balance, and putting like 10 pounds of load is not going to, if my repair can't hold 10 pounds, I'm probably doing a bad job. So I let them put a little bit of compression down just for balance and whatnot. But we tell them toe touch to kind of hope that they won't put weight down. Everything else for me, with almost no exception, is weight bearing is tolerated, brace locked in extension. Those vertical tears, the meniscocapsular tears, the bucket handles, those all heal with compression. So we want to heal those. But radials, roots, ramps, I forgot to mention those, the back
ramps.
Posterior medial meniscocapsular injuries, and transplants. You need time, just like a fracture, for your body to set it, to kind of get the glue going. So we can't load those too much. And then all meniscus repairs, I ask them to minimize load inflection beyond 90 degrees for 3 months, which is kind of miserable for the CrossFitters and those athletes that really, yoga, Pilates, they really want to get into deep flexion. But we try to advise them not to, because I just think, you think about tendon, meniscus, ligament healing principles, 3 months is really a good time, give or take, to start progressing that.
Did you say loaded?
Loaded. Yep.
So
yeah, they can get all their
do,
motion back right away. It's just
yeah,
loading.
okay.
So like flexion, squats,
weight bearing.
lunges. Yeah.
Gotcha. In this study, Rachel, they talked about increased pain, some swelling, and pain at the joint line following lateral meniscus repairs, not so much with medial. Do you see that commonly after you repair it? And if you do, or even why do you speculate they felt like they saw that in this study?
It's hard to say. I don't necessarily see that more on my lateral repairs versus my medial repairs. I think a lot may depend on technique. So, and we might get into this, but all inside versus inside out. And if there's an incision on that side of the knee versus not, sometimes the implants that we use can be prominent and those can cause some pain. The lateral side, there's a lot of superficial skin nerves, just like there is on the medial side, and that can get a little hypersensitive. But my practice has not reflected that more lateral repair patients have joint line pain compared to medial repair patients. Unfortunately, as you saw in this paper, and as I'm sure you guys know in your own practices, patients have joint line pain after meniscus repair sometimes, and it can be unnerving to know, is it a re-tear? Did it not heal? Is it scar tissue? And MRIs are not perfect for this. So that part can be difficult.
I was just talking, I want to see if you agree with this or not. I was just talking to we were talking about meniscal repair rehab last week and today in class with our students. And I was trying to explain to them that if I see someone, you were talking about the importance of the lateral meniscus. And if someone has our protocols are really just kind of weight bearing is tolerated and meniscectomy protocols, progress is tolerated. But I rarely treat people just like that if they have a decent sized lateral meniscectomy, I almost let them go a little slower at first. I mean, I don't like push them like I would maybe a medial meniscectomy, and I don't know if it does any good, but I don't think it can hurt. So I mean, what I'm saying is, you know, if they want to stay on the crutches a couple of days longer or another extra week, I don't like push them to get off. And if they're not progressing as fast, I almost try to slow them down a little bit. And I don't know if I'm doing anything or not, but it just seems like you shouldn't rush that.
Yeah, I would agree with you.
Disagree?
No, I think, I mean, not just for lateral meniscectomies or repairs, you got to know your patient, right? No one is a textbook. So if something's not right or not progressing the way with your years of experience, you're like, this is not normal. It's not anything I'm concerned about, but we need to pause for the cause. We need to take a little break. You know, I tell my athletes, I have a standardized treatment protocol. It's on my website. We'll tell your agent, we'll tell your coach, et cetera. But if you're weeks ahead with certain limitations, like I can't let an ACL that's that far ahead progress further than, you know, what some standard.
Yeah.
But if you're weeks ahead, I'm not going to limit you. And if you're a little behind, it doesn't mean anything's failed. You know, everyone responds at a different rate. And so, yeah, I think your intuition of assessing the patient and not, it's like we tell patients, we treat people, not pictures. So I don't treat the MRI, I treat the person. Assess the person in front of you, the patient in front of you, and you know, right? You've done enough. And for your younger therapists on the call, the students, you will know. And if something doesn't seem right, that's when you phone a friend, right? You call your mentor, you call Rob, you call Phil, and you say, man, this guy should be here, but he's 2 weeks behind. Do I need to send him back to the doc? Is something wrong? And then lastly, I would say, if you're ever caught in that situation, you just don't know if something's right. I love when my therapists give me a call and say, Rach, I've got one of your peeps. This is not how they usually progress for you. This is what I'm going to do. Do you want to see them? Is this okay with you? And that kind of full circle communication is just so helpful for me. Maybe there was a nuance in that surgery that didn't come through in my op note. The patient didn't know. And maybe I failed to articulate that to the therapist because, you know, I'm one of those surgeons sometimes. And so we all kind of come together and figure out what's right for this patient.
Yeah, we've talked multiple times with multiple different physicians on here, the relationship you have with the surgeon and how that is crucial to be able to talk to you and get feedback from you and you to contact us and talk to us too. It's invaluable. Yeah. Okay, let's move to the second. Or Phil, do you got any questions? I've been hogging the
I'm just learning. I'm just soaking
this
up. This is awesome.
Okay, so our next study is by Filippo Migliorini, I think is how you say it. This study compared inside out versus all inside arthroscopic meniscal repairs in terms of patient reported outcome measures, failures, return to play, and symptoms. And Rachel, you were right on track. You brought it up just a couple minutes ago, talking about the inside out and all inside meniscal repairs. Definitely, I think that's something that we could have you try to explain to us so that we better understand. I know sometimes I even kind of don't fully understand it. So my guess is the students on may not understand it, and more than likely probably some other therapists too.
Yeah, so it boils down into two different techniques to do the same meniscus repair. So all inside refers to the surgical repair being done all through the scope. So you're using different fixation devices, and every company makes little widgets that we use to fix the meniscus. Basically sutures, but sutures that come on a cool little device that you can deploy inside the joint to stabilize the meniscus to the capsule. And again, many different ways to do this, but almost every company that we work with has an ability to take this small device that's basically the size, like if the scope's the size of my finger, the meniscus repair device is like 1/4 the diameter of that. So it's very skinny, very narrow. And the advantage to all inside is it's a little quicker to do the surgery. There's no need for extra incisions. So there's potentially less dissection, less scar tissue, less pain in theory. And you can get to places in the knee that sometimes with the other techniques can be a little bit more difficult, particularly for the posterior meniscus tears. The all inside devices can be advantageous. The downside to doing it all through the scope is that It's expensive. So each of those devices costs way more than a single suture does for the inside out technique, which I'll explain in just a second. So if you own your own surgery center or you have concerns about cost, no difference in cost to the patient. The insurance company pays for the meniscus repair. I've never had any insurance company yet. Please don't advertise this, but no one's come at me and said, do all inside versus inside out or vice versa. But it's expensive. And as you all know, the back of the knees where we say big red, big blue, and big white are, right? That's structures that I don't ever want to see or even think about, although I'm always thinking about them. As a surgeon, the popliteal artery, vein, tibial nerve, etc., they're in the back. And so when you're doing the repair all inside, all through the scope, you're putting these devices aiming toward those structures, and you have to be very careful not to injure them without seeing them. So that's all inside. Usually we're putting in a minimum of 2 all inside devices to repair the meniscus. And I've done a couple this week. I did a meniscus transplant yesterday. I think we put in, actually I did a lot of inside out for that, but I did another one a couple weeks ago. I think we put in 7 or 8. I did a big bucket handle last week, put in 7 or 8 of these all inside devices. Inside out, same concept. You have the scope in the joint and you're going to come through the other incision, the other portal with a needle-based device, and it's basically a buddy system of needles. So there's these 2 long needles, and in between them is a loop of suture. And so you take the meniscus needle, and there's these guides to help guide it into the right spot, and you put the needle from inside the joint through the meniscus, penetrates through the capsule, and then comes out the skin. And then you put the other needle, its buddy, where the suture's attached to it, in the same exact spot, just a little moved over to make like a mattress. And then you have both of these needles exiting out the skin on either the lateral, if it's a lateral meniscus repair, or medial, if it's a medial meniscus repair. And then you'll ultimately tie those sutures down after making an incision in that skin area. What we typically do for inside out is we'll make that incision first. So it's about a 3 centimeter incision, either along the posterolateral joint line for lateral meniscus repair or posteromedial joint line for medial meniscus repair. And we make this incision through the skin. So use a scalpel through the skin. And it's just this big. It's like 3 centimeters. It's not a huge open incision. And then you dissect between some anatomical layers until you can get your dissection plane right between the joint capsule, which will be in front of you, and the gastroc tendon, which will be behind you. And if you can get your finger in that interval and then ultimately a surgical retractor, you then can pass those inside out needles without worry, if your retractor's in the right spot, of injuring those structures in the back of the knee. Because that retractor is keeping big red, big blue, big white behind you. And as long as you're in front of the gastroc tendon, you're going to be safe. What are the advantages of this? One, the needles are usually a little bit smaller in size than the all-inside device, so you're causing less damage to normal meniscus tissue to get the sutures in. Number 2, much cheaper. Number 3, in theory, a bit safer because you have that retractor back there. What are the downsides? Incisions take time, and we call it pitching and catching. You have to have more assistance to do this. You have to have an assistant to pitch the needles in while I'm holding the scope and positioning the guide on the meniscus in the right spot. And then I have to have another assistant who's skilled at holding that retractor and retrieving these very sharp needles out of very small incision that you can really not see out of very well. And so if you don't have a skilled assistant, let alone an assistant at all, you could potentially cause more harm to the patient. Yeah. That's kind of the big picture. And often we employ a little bit of this and a little bit of that for big meniscus tears.
That's great. That's great. That should help everybody, I think. Phil, can you this was a systematic review and meta-analysis, and they used, I'm going to give you a break for just a second. Rachel, you can get a drink or rest your voice for just a moment. You've been talking like constantly, doing great, doing a great job.
Doing great.
Yeah. Can you explain the Coleman methodology? I can't talk tonight.
No.
The Coleman, I'm just going to call it the Coleman score methodological. So I think I spelled it wrong or something. Methodology. Yeah. No, methodology. Yeah, score. Okay.
Methodological. So methodology score is actually, it's interesting because most of our systematic reviews are graded on quality using the Amstar tool. And that tool is specifically designed for looking at intervention studies. And to me, that's the gold standard for looking at quality and grading systematic reviews and meta-analyses. The Coleman methodology score is really focused on just surgical interventions. It has fewer criteria, and it does include the retrospective studies, which I'm not too sure I would like to see in a meta-analysis because of the bias in those types of designs. So they included, level 1 through 3, which level 3 could be a cohort type study and not a randomized controlled trial. So I hold this review, and they call it a systematic review. They don't call it a meta-analysis. They really didn't do a true meta-analysis. What they did was actually just collapse all the data together. They didn't run any forest plots or anything like that. So this one to me is a little bit lower quality. And the method, one more last thing to give Rachel one more breath before she jumps back in. What's interesting is the Coleman methodology, from what my research was, it was simply developed by some physicians that started using this in a paper and didn't do what I would call due diligence, like a Delphi or a group of people that actually came together. It was just done by one physician who published a paper and used this, and it became the Coleman methodology that's used in a lot of surgical studies. So I'm going to stop there and let Dr. Frank continue to amaze us.
Yeah.
I mean, I agree with everything you just said, and I think you perfectly summed up the orthopedic literature and specifically the sports medicine literature in that there's a lot of bad data, right? Because but there is, and that's, there's a lot of humbling data. I think these papers highlight the humbling statistics regarding meniscus repair and outcomes and whatnot. But I preach to all of our students, residents, fellows, and even colleagues when we're at meetings. A lot of times people just read the abstract or they read the headline if that paper makes it to mainstream media, and it can be completely misleading. The biggest one that comes to mind is kind of the sham surgery versus real surgery for meniscectomy and the methodologic flaws. And anyway, I would say whenever you're reading a paper, if it's orthopedic and specifically if it's sports medicine, you can find another paper to give you the exact opposite outcome. So you just have to find what you want. You can find evidence to support it. Our job is to apply real evidence to real life patients. And so we don't do as surgeons a great job of prospectively collecting data. I have a prospective database, but I'm one surgeon. I do about 500 or so surgeries a year, and many are complex that I don't do 500 meniscus transplants a year, right? And so it's hard to get big data prospectively to look at that. And then it's hard to pool that data to make meaningful statistics that other surgeons can use. And so that's why these orthopedic book reports come out, these systematic reviews and meta-analyses with, unfortunately, some poor data in, which leads to poor data out. All that being said, with this paper and the other paper, and I've been a part of many systematic reviews, and again, it really is a glorified orthopedic book report. There are some take-homes we can get from these types of papers. I would just give everyone caution on applying generalized conclusions to a specific patient.
Phil preaches that monthly. It's like a broken record, but it needs to be said. Yeah.
Thank you, Dr. Frank. That's exactly right. Is that people just don't get into the methodology of these, and you really can't generalize this. You have to take it like you said, one patient at a time. You don't treat the picture, you treat the patient, and don't use the paper to treat the patient either.
Totally.
So this study, the systematic review, said the all inside repairs resulted in greater rate of re-injury, but also a greater rate of return to play at pre-injury level. So a greater all inside repair, greater rate of re-injury, but also a greater rate of return to play at pre-injury level. So my question, Rachel, is do those really two things kind of go hand in hand? Meaning if you're participating at your pre-injury level, do you automatically put yourself at a higher risk of re-injury?
It's so hard to draw that conclusion. I think that's one logical conclusion. I think another one, you've got to really tease out medial versus lateral. You've got to tease out the sport, and you've got to tease out if concurrent procedures like ACL reconstruction, et cetera, were done. The last thing is really understanding what return to sport truly means. And it's return to sport, but is it at the same level? Are they continuing to participate? And then finally, tear patterns. So most of us who see bigger tears tend to do inside outs more frequently than all insides. Bigger tear probably means more destruction and more need to heal, more difficulty getting back to sport. But then if you do get back to sport, maybe that means everything's going to be successful and your chance of re-injury goes down. All insides, smaller tears many times, not always, but kind of the exact opposite. That being said, anytime you go back, you can tear your meniscus just like you tore it before I fixed it, right? So it's
Exactly.
not like
But
I'm giving
there's
you
no
anything better.
guarantees. No
Yeah,
guarantees at
I
all.
mean, I wish I was better, but I'm not giving you anything better than what you had before you got to me. And so, so you can have a re-injury, and that's one of the hardest things for patients to understand. They're like, "Well, I went through all this surgery and rehab." Well, you tore it the first time. You can tear it again. We try to prevent that, but it does happen. So I think it's an interesting take home. It certainly makes for a great headline, but when the devil's in the details. I think for me, the most important take homes of this paper and the other paper, as well as really every meniscus paper that I read, is return to sport is like 70 to 80% in the best of cases. And at the same level of play, it's lower. And I'm sure you guys have seen and heard orthopedic surgeons say, "You're going to do great. It's going to be perfect. You're going to get back to every single patient that they treat." And if they did that and that happened, I would give up my practice and send all my patients to that surgeon because I don't have those outcomes. I have real outcomes. And unfortunately, some patients just can't get back to what they want to get back to. I was one of those patients. Now I live a very good, happy quality of life, but I had to change what I thought was a good, happy quality of life to match my needs. So, and that's, I think, another, it's a little tool that I have when I talk to patients about expected outcomes. Our hope, get you back to 100%, forget you ever met me. Reality, that may not be the case.
Great. This I think is a good question for this this whole talk here. What time point would you recommend? And it's probably going to depend on the tear type and how you repaired it. But at what time point would you recommend loaded weight bearing with rotational activities? So like simulating cutting movements, or they said like tennis and golf for root repairs for younger individuals or older adults.
Yeah, I kind of use 3 months as a rule of thumb for weight bearing loading, whether that's rotational loading or vertical loading, impact, etc. Why 3 months versus 11 weeks versus 13 weeks? I don't know. We just kind of say 3 months, but I kind of use 3 months. I feel like the first 6 weeks, especially for roots, they're so shut down and atrophied that I'd hate for them to go back too early and pop their ACL, right? If they're not ready. I do love getting them going on BFR. As soon as the incisions are healed, we start BFR. We try to start BFR. I love dry needling. I love all the modalities, like do it all. I think even if you don't feel like sometimes they're doing anything, I think up here sometimes the patients really appreciate the hands-on, and that helps with the healing as well. There's a lot of controversial data. This is not a BFR focus, but there's a lot of controversial data on that in terms of does it help, does it not make any difference? We love it. I mean, as surgeons, I love it. I think it does make a difference, but I think that it's got to be done properly, and I don't think that you restrict enough blood flow during the workout sessions to impede healing. I think some surgeons and docs worry about that for repairs. I don't think the cuff on for X amount of minutes, X amount of sets, 3, 4, 5 times a week is again, if my repair can't stand up to that, I'm probably doing something wrong. But this is not, we're not talking about restricting blood flow for 2 hours at a time. I think that would be a different story.
Yeah. Did you have, were they using blood flow restriction when you had your surgeries?
You may not see it, but I have a lot of gray hairs here. So those surgeries are so long ago. I don't think my PTs were using it, but I certainly got many needles and good days and bad days with those, but I think they're great.
You should go down to the gym and just have them put you on it and do some exercises to see what it feels
I've
like.
got some cuffs. I do upper and
you do?
lower.
Okay.
You can't tell because like you just can't see my muscles through my scrub, but they're working.
They're there. I believe you.
I think that question before it too, just to clarify on what you consider when you say load, do you consider body weight in those deep reflection as load, or does it have to be with additional weights or resistance above body weight?
Yeah, I think for roots, ramps, radials, transplants, I really don't like even body weight lunges and squats below 90 degrees. Happy birthday if it's your birthday. I see a balloon floating back there. Love that. Happy 21.
It was in January.
Happy belated.
My nephew's obsessed with balloons and got me a balloon in February for my January birthday.
Hey, I'm in for it. But yeah, so I really don't even like the body weight below 90 and for lunging, squatting. I will let them, if they're a hard golfer with a brace on, I will let them start putting. I'll let them start hitting some wedges. I ask them not to drive, off the driver, and I ask them to, or off the tee, and I ask them to use the cart if they're going to be doing more than 9 at kind of 10 weeks plus. We have some diehard golfers who just, I think mental health and emotional health is so important, and we're shutting down. Many of these athletes live on working out, and we're shutting them down from things that they love. And there's only so much, I call it torture. There's only so much core work you can do when you have a lower extremity injury. And like every day can't be arm day. So I do want to make sure they have outlets. And golfing is one of those that, with, if they're going to keep their legs straight and not twist, and then depends if they're righty or lefty and which knee and all that. But we'll try to be lenient. I have some bowlers who, we try to talk about that just to give them joy in life. My rock climbers are for sure the hardest ones in this category because all they do is load and flexion, and you can't predict when they're going to do that. So that's always a difficult discussion because there's very little I can let my rock climbers do until that 3-month mark.
Billy is asking a question here. Are there surgical variables you see that contribute to loss of flexion motion after meniscal repair? And then he said, for example, all inside versus inside out, tear location, etc.
There's always those patients who are going to get stiff. So this is a great question. I get my patients locked out in extension leaving the operating room. And if I have any concern about stiffness, we leave them locked for a couple days, and I'll get them a CPM just to start something. But I'd rather fix a stiff flexed knee than a stiff extended or flexion contracture knee any day of the week. I do think the repairs that are more at risk include those bigger tears because you're just doing more work. You're mucking it up a bit more. Number 2, it's a technique thing, but I think the position in which, if you're doing an inside out, the position in which you tie your sutures down is really relevant. So often we're fishing those sutures out of that incision at the end of the case with the knee in flexion, or we're tying as we go, especially for we do the lateral meniscus repair with the knee in flexion because we get the knee in a varus or figure 4 position to really open up that lateral compartment. And that's nice. It's also safer for the blood vessels because in flexion, they kind of move to the back further. But if you tie those sutures down, and I know many surgeons who do that right then and there with the knee in flexion, just think what's going to happen when they try to extend their knee. Like those sutures are going to pop or the knee's not going to extend easily. So my technique, and I learned this from my mentor, Brian Cole in Chicago, is you tie those sutures down at the end of the case. So you pass them all, and then you tie them at the end of the case with the knee in extension. And that way they're not going to lose their flexion. The medial side, you're doing it with the knee in flexion, or excuse me, you're doing it with the knee in extension because when you do medial meniscus repairs, you put the knee in an extended valgus position to really open up the lateral side. We call it valgus hyperextension, basically. And you're really trying to pop that MCL a little bit. And sometimes we do pop the MCL to get more access to the compartment. So those you're already tying down in flexion. So that's fine. Sorry, tying down an extension.
Yeah. Ed wanted to ask a question here. I think you kind of answered this, but I'm going to ask it just for him, just for his sake. Meniscus medial root injury in a 60-year-old, repair or removal? I thought you said you'd repair, right? If it's
as long as they don't have significant arthritis. And because the whole goal, you want to treat their pain from the tear, but the goal of a root repair is to preserve the joint. So if they already have significant arthritis, osteophytes, varus malalignment, to me, that would be cruel and unusual punishment. I would make a paycheck, but that would be cruel and unusual punishment to put them on crutches for 6 weeks. I would never do that. And I don't take them for a scope to debride it. That's a no-go for surgery in my mind. That's unloader brace, physical therapy, try to get the quad glute core going, injection, etc. If they're 60 and they have post-op pain and they've already had a repair, you got to investigate that. I think my roots tend to have pain 10 to 12 weeks up to surgery, and then they kind of turn a corner at that time. We're also doing a little technique called centralization that Aaron Critch at Mayo Clinic has really taught us to keep the meniscus from extruding, which we think helps with recovery a little bit and healing. But yeah, I wouldn't, I've repaired roots in patients in their 70s if they're physiologically young and they don't have arthritis. That being said, in their 70s, they could say, I'll live with this for a little bit and let's do a knee replacement because they're at a great age for that. But the wrong answer is to take them to scope them just to debride it. We know that that's a no-go. And then lastly, success rates with roots are 75 to 80%. So I tell patients 4 out of 5 heal, 1 out of 5 doesn't. I expect all of you to heal, but 1 out of 5 won't. And that's really the data. That is my practice as well. That's the nature. Lateral roots, different story. Nearly all of those heal, but the medial roots, there's always going to be one that, despite your best effort and their best effort, and even if they're the skinniest, most healthiest, most bolder patient that we get, because my bolder patients are super healthy, they sometimes they just don't heal.
Awesome. Well, Rachel, we've only got like 3 minutes left to fill up the hour here. I can't thank you enough for joining us. You thanked us for coming on, but we definitely thank you. We know you're busy. You said you just like left surgery rush to get to this meeting. So we appreciate your time. Like I've been telling you on the email, we only did 2 of the 3 studies. We would love to have you back anytime you want. Let us know. We'd love to have you back again, and we could talk articular cartilage.
I'm happy to talk all things knee. I'm a big knee nerd, and I literally could do this all day. I mean, I sort of a little behind in clinic because we end up talking. But I appreciate you having me on and for getting this going. And again, for everyone on, thank you for, especially if you're East Coast or wherever, thank you for spending the time, because I know it's late and we all have not enough hours in the day. So thank you.
Thank you very much.
Thanks so
Ash,
much.
you need to close out anything?
No, just a reminder, certificates go out within 24 hours. If there's any issues, you can email me. But yeah, other than that, I echo everything they said. We have a group text on the side. I was like, she's so freaking awesome. You got to come back.
Yeah, you got it.
If I ever hurt my knee, I'm flying to Colorado.
You'll have a doc wherever you are, but I'm always happy to chat. Let me know, and I'll tell you straight up what I think. That's for sure. Good, bad, or ugly.
We appreciate that and appreciate your support of us as a profession as well. So have a great night, and thank you, everyone. We'll see you guys next month.
All right. See you guys. Thank you.
Thank you.